Well, my name is Paul Dallas. I'm with the Internal Medicine Department, and I've been here a long time. Actually, I've been here probably longer than any other faculty member, with the exception of two people, since 1991. So a long time. So I'm very happy to welcome the Pediatrics Department, because I was here before there was a Pediatrics Department, and for you to welcome me. And so what we've been tasked with today, Kelly and I, are to talk about teaching in a new way. Ambulatory teaching, but it can apply also to teaching in the inpatient setting. So the first thing we're going to do is actually tell you a little bit of about what I call metaphysical teaching. Anybody heard of the metaphysical poets? Actually, you haven't heard the metaphysical poets, but you've heard many things the metaphysical poets wrote. They were poets in the 1600s. John Donne was a classic metaphysical poet. He wrote the shortest poem that there ever was after his girlfriend broke up with him, and he was sad. John Donne, Undone. And he also wrote a classic quote, which Hemingway later took: ask not for whom the bell tolls, it tolls for thee. And the other one was Alexander Pope, who classically wrote, for fools rush in where angels fear to tread. And the metaphysical poets went beyond what they saw. They were, metaphysical. Also give a talk about metaphysical exam, where it looks like you're doing magic when you're pulling something out of a hat from a cool physical exam finding. Well, this is what I call metaphysical teaching. But it looks like you're in the person's brain. You know what they need to be taught. Wouldn't it be cool if at all times when we were talking with residents that we knew exactly what they needed, without resorting to what the students don't like? That's a constant questioning, right? And they feel like they're getting pimped and they're getting put down or whatever. When all we're trying to do is just to figure out where they are, so we can teach them from beyond that. So I subtitle this "Reaching the Learner," how you reach the learner so you can teach the learner. And the techniques I'm going to talk about a little bit today are used by TSG, by law enforcement, by lawyers. I've actually sat and evaluated juries to tell lawyers which of their jury members were on their side, which they had to reach, where they had to stand to reach this particular juror versus another particular juror. So it's really cool stuff. And it's about a 3-hour course that I used to teach over at Breakout College on this for the business class, but this is for medicine. So I have no disclosures that are relevant to this talk, and we're going to try to get these objectives in the next about half hour, and then Kelly's going to talk about some really specific things, which is the last objective. So we're talking about resting faces a little bit, and how you use them in teaching. We're going to talk about how you recognize those resting face patterns, how to define a person's primary representational system, how they think. You don't know, or they don't know, this is what you're doing, okay? But this is actually what we're doing. Recognize the importance of microexpressions in our learners, and then we'll talk about some key words and phrases, because many times people say, you got to teach to the learner. Well, how do you do that? What do you do? What words do you use? So this is the breakout session. That's a breakout. Group, the folks in one, yeah, good. The folks in one are going to ask the folks in three, the threes, two questions. And what's going to happen is you're going to answer those questions, but don't be eating at the same time you're answering, because this will actually mess things up. It really will, and there's a reason for that, and I'll tell you about it. Later. You guys go ahead and ask the questions that you're going to ask, and make sure that the person's not otherwise involved with some other thinking going on.
All right. So what is something that is really important to you? Think of it right now. When was the last time you learned about something?
Well, the first thing I want to talk about is resting faces. Okay, and why do I want to talk about resting faces? I've had residents who are sent to me because they have evaluations that are problematic. And this one resident had this problematic evaluation over and over again. He's not paying attention. He's not involved. But then when you got to talking to him, you'd say, what did we just say? And he would spit everything out. It was clear he was listening, but he had this resting face to suggest that he wasn't. And the resting face was similar to this, in that he had lips.
Pursed lips, he is.
No, not classic pursed lips like when you get with COPD,
Yeah.
but they jutted out like this. They were closed tight and jutted out like this. Yes, exactly. And so that gave people the impression that he was not listening, that he was not engaged. So in sitting down and talking to him about how he can improve in his interactions, I told him, listen, pay attention to how you part your lips. Open your lips a little bit. It's not anything new, because in some older societies they say stuff like this: "Έμεινε με το στόμα ανοιχτό" in Greek. He was sitting there listening with his mouth open. You don't listen with your mouth open, right?
Right.
But it suggests that you're open to getting some new information. So this is a resident that we had to teach about how to appear to us so that we can want to teach him. Does that make sense? Because it's not only the person's resting face, it's also how we respond, sort of like a counter-transference type of thing, how we respond to that person. So if you saw this face, okay, Bill Maher down there, okay, what does that face look like? Arrogance. Doesn't it look like arrogance? Okay, and there's a reason for that look of arrogance, and I pointed out to you. Okay, it's the down-going brow with the corrugation in the middle. That's arrogance. Okay, that is arrogance. Now, if he had Botox there in the middle, you'd have a problem. Okay, but the straight down-going eyebrow with that in the middle is arrogance, and plus the slightly upturned lips. He may not be arrogant. I don't know the guy. Okay, but this is the look of arrogance. Okay, and we know that these faces are important because even in the pediatric, in the newborn literature, yes, 2 and 3 month old babies, you put a square face in front of them and you put an oval face in front of them, and where do they look? The oval face. They turn to the oval face. Why? Because they're already ingrained. It's a much more pleasant face. The oval face is a much more pleasant. Square face is a less pleasant face. Now, what do you think about Helen Hunt? What do you think about her? She's nice, right? Helen Hunt's nice. I don't know Helen Hunt. She may not be nice. She may be terrible. She may be an axe murderer. But here's another thing with the eyebrows actually sloping downwards, but not corrugated in the middle. And the lateral epicanthal fold is actually covering. So when she gets older, and she's gotten older from this picture, this lateral epicanthal fold actually covers part of her eye, and it makes her look nice. It makes her look like she's listening. Julia Louise-Dreyfus, same look to her face. Okay, so the resting faces are kind of very important. What about these resting faces? Okay. Anybody know what this resting face is called?
Yes.
Yes. Okay. The resting, right? You've heard it before? Yeah, it's the RBF. Why? There's a reason for this. Okay. Once again, I don't know these people, but these muscles right here, the medial portion of the canines actually bring the middle part of the lip upwards, and when that happens, okay, and you have a somewhat vacuous look to the eye, there's no wrinkling up here, there's no wrinkling on the sides. It looks like it's saying, I really don't care about you, what you have to say. Okay? Have I seen this in residence? Yes, I have. I saw it in a student yesterday who came to me to help her with her personal statement. I'm looking at him going, I know you want a disappointment, but do you want to be here? And do you know that your resting face says this about you? So you're going to have a tough time in interviews if you don't know what your resting face looks like. So I tell my residents, hey, put a mirror in front of you somewhere. From a long time ago, I read somewhere it said, put a mirror where your phone is. And when you're talking on the phone, make your face look like you want your voice to go out over the phone. And another resident came to me. It's a big, tall guy, okay? And he looks very arrogant. Looks very arrogant. As a matter of fact, nurses complain about him. Other physicians complain about him. But he didn't know all this. So we started talking about what I need to do. When he smiles, handsome young man. So when he smiles, all that goes away. So I tell him, I need for you to smile more. I don't know if you saw that commercial years ago. There's construction workers. They were going to take a picture of them. And one guy says to the other, look sexy, smile with your eyes. So I was going to say, hey, man, smile with your eyes. Okay, you don't have to, put a grin on. That looks kind of cheesy after a while. But smile with your eyes so you don't get looking like this. I know my resting face. You may not know your resting face, but you need to figure out your resting face. My resting face is stern. And when I walk somewhere and I'm thinking, it looks like I'm mad at somebody. And I've had people tell me, who are you mad at? I go, I'm not mad at anybody. I'm just trying to think about, the stuff I got to do in Epic. When I get back to the office. Well, that's not a good example because I may have been mad at Epic, really. Okay? So the next thing I want to talk about real quickly, and I know we've got a lot to talk about, and it's a small period of time to do it, is microexpressions. Microexpressions. And I'll share a situation where actually interaction with a resident. We're a morning report. And we're talking and doing the standard stuff we do at morning report. And I noticed a particular resident had a few microexpressions when she was talking that suggested that she was sad. And I hadn't seen that before in her. Okay? So I asked her to stay after morning report. And we sat down. I said, I noticed that this morning when we were doing morning report, you did a fine job presenting the patient, blah, blah. I gave her classic stuff that we talk about, when we're doing proctoring somebody, what exactly you did, how you did this, how you did that, not just, great job, but specifics, right? I said, but I noticed a couple times there, you were quite sad. Would you want to talk about that for a few minutes? What's making you sad? Because I know you're a very, very meticulous resident, and there's something going on. I want to see if I can help you. And she started crying. She goes, my whole world is falling apart. My parents have been married for 30 years, and they're getting divorced. And I just don't know how to deal with that. Well, was it important that we picked up on that? Sure it was, because she wasn't going to be very open to teaching, right, if she's thinking about her whole world falling apart. So as a teacher, I would have to know where she is at a particular time. If somebody's angry, if somebody has something going on, I need to know that. I need to call that, is what I tell people. Call the game. You can't know how to shoot a free throw in basketball unless you know exactly where you're supposed to put your feet and what line you're not supposed to cross over. Does that make sense? Okay. So microexpressions, and this started many years ago in the 70s by a number of psychiatrists, actually. Paul Ekman, probably the most famous one, and his protege, Matsumoto. These facial expressions, are the same across cultures. Interestingly, they're the same across primates. And when we see them in non-primate animals, we still ascribe to them the same emotions. When you see a lion that has its corrugators like this, you go, lion's mad. It's gonna attack. The other day, a bison kicked a little 9-year-old girl up in the air. I don't know if you saw that. Well, the bison didn't let anybody know that he was going to do that, except he did, because his tail was up in the air. Now, if you happen to know that a bison with a tail up in the air means I'm getting ready to charge, you would know that. But, we physicians can't really put their tail up in the air and give us a clue that they're going to do something angry, but there are other things. And they're not taught. They're innate in humans. You see babies doing these expressions, right? They're going like that because they're getting ready. They got a little, they're a little colicky, or they got, a couple of pounds of stuff in their diaper or whatever, But they're making a face, and you go, every time it makes a face. I remember when I was doing pediatrics, and they told us, pick up your kid. We'll put her here when you're listening to them. That's what they told us back then. And the first kid I picked up had a malabsorption syndrome. And the next thing, and he had a funny look on his face. The next thing I saw was this green stuff all over my new tie and shirt. So I didn't do that anymore. So governed by emotions, and actually used in law enforcement and TSG. That's why every time they look at you and they say something like, are you here for business or pleasure? Why do they ask that question? They're looking at you right in the eye. Are you here for business or pleasure? They're trying to see if you're going to give away something that tells them that you're lying. And there was recently a $2 million study just on microexpressions, so we can use that for our benefit. These microexpressions will last less than a second. If they last more than that, people are lying. People are lying. Okay? Oh, it's a surprise birthday party. No, it's not, because your expression lasted too long. You already knew about that birthday party. Okay? Gives clues to the person's emotional state, and it's what I call emotional incontinence. And you can tell a lot about what's happened to people with this emotional incontinence. They may be trying to hide it, but it's there. Like the young lady I told you about. It's not well controlled by individuals, and in order to recognize microexpressions, you have to be able to recognize your standard expression. Who, by the way, is best at recognizing microexpressions, men or women?
Women.
Women. That's been looked at over and over again. For whatever reason. I don't know why that's so, but yeah, whatever. It may be helpful when you're at home and you've been told to take out the trash, man. What's that? That's right. It's not. You should have known what I was thinking. Okay? You should have known that's what I wanted for Christmas. Okay? This is sadness. Okay? You recognize the sadness, right? But what causes sadness? The drooping of the eyelids, kind of losing focus, and the slightly downturned mouth. That's sadness. That's what I saw in this young resident. Okay? And I have to call it because I have to know how to teach her. Okay? And you may only see it for a brief. And by the way, if you want to get better at this, on the internet there are actually ways you can they flash it. They have you commit to what you thought you saw for a microsecond, and you can get pretty good at this actually. Okay, is this person happy? Yes, this person's happy. Why do you know they're happy? They got the crow's feet going on. This particular muscle right here, called the zygomaticus major, pulls your lips up towards your ears. This is important. Okay, and the cheeks go up, so this is why you get crow's feet all the way along here. That is happiness. That is happiness. Okay. So exactly this, right? Zygomaticus major pulls the lips up toward the ears, as opposed to the risorius or the sardonic smile. We recognize this as what? A fake smile. If some resident is ingratiating to you, or looks like they're trying to be your next best sycophant. Okay, that's what you see. Yes. Oh, yeah, Dr. House, I understand. You don't understand, man. Come on. What are we talking about here? Here's some smiles from the internet. This is Rachel Ray. Okay, is this a real smile or fake smile? That's a fake smile. See how flat her upper lip is all the way across? Is this a real smile or a fake smile?
Real.
That's a real smile. Look at this. Look at this, downturned eyebrows, like we said, crow's feet. But here's the kicker. She's been blind for birth. She's never seen anybody smile. How could she know to smile like that? There's some innate thing, going on. So you can tell that in your resident. I hope you don't see this in your resident, which is contempt, which is classic. We have a president right now who does this all the time. Just watch. Okay? One side of the mouth goes up like that. That suggests contempt. If you want to see something really nice, we don't have time to play it here. But Alex Rodriguez, when he was asked by Katie Couric, have you ever used performance-enhancing drugs? And he goes, no, I've never used performance. You're just lying to me. You know why? Because you just told me you're contemptuous of me and my question. And you're not even going to answer it truthfully because I am an ant. And you don't think you need to. This, by the way, is very dangerous. This is very dangerous. When you're Hitler and you kill 12 million people, right? Are you doing that out of anger? No, you can kill one person out of anger. But you can kill whole swaths of people out of contempt. You're not even that important to me. So this is actually very, very dangerous in big things. So that's what I'm saying. I hope we don't see any residents like this. So the next thing we're going to get to is your primary representational system. And this is what we did. We tried to do just a few minutes ago, and I'll explain it in a second. If I know how you think, I know how to teach you. Okay, and it's not only applicable for teaching, but also in patient care. We had a lady one time who came into the hospital, and she was there for 3 weeks. And two of the best communicators I have ever been, blessed enough to listen to were her attendings. I would literally sit and listen to these guys. Our cubicles were back to back, and I would sit them and listen, talk to their patients, and I would write stuff down about how they phrase something. Oh, I really like the way Don Stein would just phrase it, or Rick Butler. So they were our attendings. And so the residents, one of the chief residents is now in a huge administrative position here, still remembers this patient. The resident said to me, she won't leave. We can't get her to leave. And she's been in the hospital for 3 weeks. So I walk in, and what did I do classically? I went to the patient's right side to shake her hand. Within about 30 seconds, I realized that I had done something wrong already, because she moved her eyes down and to the left when I introduced myself, down and to the left. So her primary representational system was what we call internal dialogue. She's a thinker inside her head. So I had to use terminology, and I had to place myself in a place that was comfortable for her to look. And we do this with some of the students at Roanoke College, where I'll walk around, and I will stand in a place that will make them uncomfortable. They're not a visual learner. They're not a visual thinker, and I will stand in their visual field, and it will be uncomfortable. They can't look at me. If I sit down and go to the other side, and even with them, which is auditory, they'll sit there and keep my gaze for as long as I wanted to. Okay. So I said to her, would it be all right if we came back this afternoon, sat down a little bit, and talked about your issues? She goes, sure, I think that would be fine. I think that would be fine. I think. I'm an internal dialogue. I'm a thinker. So I came back in. I told the house officers before we went in, you know what we're going to do? I'm going to go in and sit on her, pull up a chair at her left foot. Okay? You guys are going to all sit behind me at her left foot. By the time we finish, she's going to ask us to go home. Oh, no, it's not going to happen because Dr. Steinweg and Dr. Butler weren't able to get her out. So, Mrs. Jones, this is what's going on inside my head. This is what the little voice inside my head is saying. The little guy that's talking to me is saying this inside my head. What do you think we should do? Whatever. We've done this, whatever. Well, I think we should consider this. Consider, because you got to think to consider, right? Let's consider this. Let's do this one test today, and maybe if it's negative, we can get you home tomorrow. She goes, I got another idea. How about we do that test as an outpatient, and can you let me go home today? Now, she didn't know that something happened there. I made her trust me. I made her trust me because I was in her head already. I knew what her primary representational system was. I used words that were geared toward her primary representational system. So if you know your student, for instance, is a visual learner, you're going to say, do you see what I'm saying? Well, who sees what you're saying? We have, I know a person who's blind, been blind since he was 5 years old, and he always says, do you see what I'm saying? Because he's still a visual, his primary representational system is visual, even though he can't see, and he hasn't been able to see for 60-some years. That's fascinating to me, listening to him talk. And he's going, you see what I'm saying? Et cetera. So the story here was, we had a resident one time. Anybody ever, some of you are older, some of you are younger. Last time you did a gram stain. Okay, right, yeah, some of them, yeah. When I asked that of the residents, there's nobody raising their hands. You used to have a house officer's lab, you would go and do a gram stain, make a diagnosis. Oh, there's a Kenya stain. This guy's got, TB. Send him home from the emergency room, not send him home, but we already know what he's got. Send him upstairs with TB. Now you got to wait a couple of days to get the stains back. But, so I always ask my residents to give me their gram stain results, what they saw themselves. And this one resident says to me, so what did you see in the gram stain? And he looks over toward his left. I was like, why is he lying to me? Why is he lying to me? He's not looking up toward his right, toward his left, which is visual remembered. He's actually lying to me. He's remembering something somebody told him or something he said. And I couldn't figure out, why he would lie about a gram stain. And he says, I didn't see anything. Turns out the guy had gram-positive coccobacillary forms, and he had H. flu, and he should have had seen something. But the student came to me afterwards and says, you know what, when Dr. So-and-so, who was a preacher, former preacher, we went down there, we took the gram stain, we put it under the microscope. He looked at it for literally a second, and then we went away. And I said, what? And the student says, I said, why did we not look at it? He says, I don't know anything about gram stains. I just want to be able to tell Dr. Dallas I looked at the gram stain. That's why he was hearing the student ask him that question. So it's just fascinating. Okay, so this is a whole other thing about lying and whatnot. So prime representational systems are that preferred sensory modality that a person uses most when they're thinking. So, and you use words to describe it. I hear what you're saying. I see what you mean. I get it. I smell a rat. Who would say I smell a rat? Somebody who's kinesthetic. Somebody who's kinesthetic. Okay, they're feeling. We had a young lady named Jessica, and family practice resident years ago, and a patient had hypophosphatemia, and for 3 days in a row, every day I tried to teach her how to replace phosphorus, and she could never get it. And I didn't know things at that time, but she had some weird eye movements that made no sense to me. I was like, well, why is she flitting her eyes around like this? Have you ever heard the thing, I don't trust them, they got shifty eyes? Because their eyes are shifting in a direction you don't expect them to shift, even though you don't know consciously why they're going that direction. Okay? You ever seen bad actors? You go, that's a bad actor. Okay? Meryl Streep is a great actress. She actually moves her eyes in the direction that she's supposed to. And I don't know if she got taught this or if she learned it or if she picked it up. But when she says things, her eyes move in the direction. I go, that's just amazing. This is real for her. She did have that memory. It looks like she had that memory or that thought or that vision. So these are the questions. What is something that is really important to you? Think of it now. And you have guarded people like Erica, for instance, who's sitting there going, I don't know what this is all about, but I'm going to look you straight in the eye and I'm going to tell you something. Okay? People who don't move their eyes, it's either a question that is so simple, what's 1 plus 1? They don't move their eyes. Okay? Or if you're practicing a lie. You're practicing a lie. Look me in the eye and say that. That's not a good thing. That's the follow-up question. When was the last time you lied? So when was the last time you lied? Erica looks up and to a visual thing, trying to remember visually. And then she looks over to her left and looks down. So she's self-talking. What did I see? What did I hear? What should I say to this person? Okay, that's what's going on inside the head. And I had a former boss who, when I was learning this, I said, how'd that meeting go? He says, he looks up, he looks over here, he looks down here, and then he looks over there. And he says, the meeting went fine. I said, would you mind if I see if I could figure out what was going on inside your head? He said, no, go ahead. I said, you were at the meeting, you saw where people were sitting, and you heard what people were saying. Now, what the people were saying made you mad because you went down here to feelings, okay? Now, it could have been love, okay? It could have been sadness, but I suspect it probably made you mad. So then you look down here and ask yourself, what should I tell Paul? Because I don't want him to know that I got mad. And he goes, that is just absolutely amazing. That's exactly what's going through my head. So you can figure this out with the resident. So how is it important? Because that's how you're going to teach them, once you define their preferred sensory modality. And here are those eye accessing cues. Some of you already have these eye accessing cues. A patient looks up, this is you're facing the person, right? Patient looks up in this direction when they're remembering something. In this direction when they're remembering an image. In this direction when they're remembering sound. Here when they're remembering or with internal dialogue, this is what I should say. How they got the little man in your head. What are you thinking? That kind of thing, right? This is feelings. This is kinesthetic. I'm going to give out the rest of these things as well. But there's some questions here you can ask for kinesthetic stuff to define it if a person's kinesthetic. Can you teach a kinesthetic learner? Jessica was a kinesthetic learner. It's hard to teach a kinesthetic learner. Most physicians are visual, okay? And the next most common thing is remembered, and there's a lot of us that are internal dialogue. I did something bad one time. At least the hospital administration thought I did something bad. And so I got called to the principal's office, and I won't tell you who the principal was. But he says to me, Paul, if we don't have the right folks here, they may need to be elsewhere, like this. He says, I wasn't, and he was doing this the whole time. He says, I wasn't suggesting that, that this is what we need to do. And why was that the case? So anyway, that was fascinating. From then on, I knew that he was an internal dialogue. So when I talked to him, I was like, what are you thinking today? What's going on? Okay, so a way to do it. So eye accessing cues, up and to the right, non-dominant hemisphere, visualization, remembered imagery, and constructive, up into this side, constructive. Remember that lady that killed her kids a number of years ago in South Carolina? She said she was sitting in the car. She got out for a second. Some crazy guy went in the car and pushed the gas and drove her kids. I was on a bike in a gym. And the lady next to me says, oh, that is so sad. She lost her kids. I said, she killed her kids. And he said, what do you mean she killed her kids? She's so upset. I said, she's upset because her kids are dead, not because she killed them. She wanted to kill her kids to get them out of the way because of the boyfriend that she had. Remember that story? Because what? When she's talked about the person who got in the car, she wasn't looking up here to something that was remembered. She was looking over to here, something she was making up of an image that was constructed. Okay?
Are we talking about this as you're looking at a person, or?
Yep. Yeah, just pass these around.
Which is right or left?
Yes, right there. Just like that, as you're looking at the person.
You can also practice it by telling a lie to yourself.
Yeah.
No, by really doing that, you can, and you'll see where you're.
So yeah, just pass these around. These are some other questions for eye motions if you want to practice these with your learner. Okay, this is a talk that's different than the ones you normally hear about how do you do this, how do you give them a feedback sandwich and all this kind of stuff you've heard. So it's about get inside a learner's head to help them help you, or to help you help them. Does that make sense? Okay. So when we increase awareness of faces, we can give that feedback. You got to be sure those people want that feedback. The guy with the pursed lip breathing not the pursed lip breathing, but the pursed lips, did not want that feedback. Did not want it. The arrogant resident actually took that feedback. And every time, he introduced me to somebody, he now introduced me to somebody, he says, this is my mentor. He's helped me so much. I can talk to people better because of him. And other things too, sit down, man, you're 6'5". Talking to somebody, you're always looking down on them, that kind of thing. So resting microexpressions and primary representational systems. Okay. And do we have any quick questions before we go over to Kelly?
I just have a quick statement.
Yep.
I was very remiss in not introducing you before. We were so discombobulated. We were trying to get the room working. I just want everybody online to know that this is Dr. Paul Dallas from Internal Medicine, who's coming to help us with one of our talks about how we can better learn about how to teach a learner, our residents or anything else. And I'm supposed to say for Sherry Wicker, he's the most entertaining talker that she has ever heard. I think you can agree on that.
Oh, bless you. Oh, no, not at all. Not at all.
What do people do who don't have a lot of internal dialogue? Do they just have an emotion and push it?
So, interestingly, we have a lot of presidents on TV, right? A person who never had any internal dialogue was George Bush. And he was just so honest, the guy. He may have been telling you something that wasn't true, but it's not because he didn't believe it. He was just saying what he found. Oh, yeah, there were, weapons of mass destruction. Well, that's what he was told by his chiefs of staff. He was very honest. Obama was fascinating in how he lied to the world. Fascinating how he lied to the world. Because you can tell he was getting ready to say a lie. I want to make this perfectly clear. Right? When you hear that, that means get ready for the lie. Clinton was a wonderful liar. I want to make this perfectly clear. I did not have relations with that woman, Monica Lewinsky. Okay? Watch. He's pointing somewhere else. That woman he depersonalizes. He says, I want to make this perfectly clear. Listen to what I'm saying because I got to get back to work. Okay? So he says all this stuff. He's a great liar. He's a great liar. But you look at his eyes. And I point this out where in other situations he's actually pointing to the person he's talking about because he's engaged. Here, he's totally unengaged. I want to make this perfect. I'm talking to you guys, but I'm pointing over here because I'm lying. So, yeah, there are people that don't do any internal dialogue. Trump does no internal dialogue. Trump is so narcissistic, okay, he doesn't really care. And that's why he's contemptuous, okay? That's why his chin is out like this. Obama was the same way, chin up like this all the time, eyes going downwards. A great deal of arrogance in that gentleman. So you can actually see, great examples of this stuff in you look at some of the senators, for instance, and you go, oh my gosh, how can why aren't people not voting for you? Somebody should be not voting for you based on what I think. Anyway, Kelly, I'm sorry.
When we're dealing with personalities that are more sociopathic,
yeah,
the ones, and we do deal with that intermittently within this. How's the best way to try to discern that when you're speaking with somebody?
Right. We would hope that we don't see many sociopaths in medicine. However, I've seen residents. I've had to watch a number of residents pee in cups over my 30-some year experience, and you get the lie right in front of you, and they've got a history, and maybe there's some sociopathy there. We had a resident who had done some things, and we brought him up in front of the clinical competency committee. And I sat opposite him, and I told the group that what I was going to do was I was going to read him, and we were going to decide what we would need to do based on whatever we heard and whatever I'm saying. So he goes like this. Watch my eyes. He says, he's looking down here. He says, I feel very badly about what happened. I know that I want to change, and on like this. But it's all internal dialogue, right? He didn't feel anything. He didn't care. And so after the meeting, and we were talking, they said, well, he's really remorseful. I said, no, he's not, guys. You missed the point. This resident is not remorseful. A tiger does not change his stripes. What's going to happen to this patient, this resident, is if we give him leniency now, okay, in 3 months, he's going to do something else that's going to get this hospital in trouble, or him in trouble, or his patients hurt, okay? Because he doesn't believe what he's saying. No. I feel differently. I feel like saying, I don't care how you feel. I do this a lot. I'm just telling you. So 3 months later, that attending who said, I feel differently, comes to me and says, you were exactly right. He's just done this, and this. We need to meet again to talk about dismissing him from his residency program. We could have saved ourselves, 3 months of hassle with this resident just by knowing. So was he sociopathic? Well, he was lying a great deal. That's part of sociopathy. But hopefully we don't get to the point where residents are killing people. But that's happened too, right? Nurses that are killing people, doctors that are killing people. Yeah, it happens. And you got to get a clue for it. We had a resident here that somebody once said, and I didn't know this guy very well, said, I don't trust him. I don't trust him. Why don't you trust him? I don't know, I just get a terrible feeling about him. Okay? We've all had that. So he finishes off here. Got in a whole lot of trouble here. Just stuff that it would be in a whole hour to talk about his stuff. He goes to another. We didn't renew his contract. He goes to another institution where he drugged 2 women and raped them, and then got put in jail and didn't reach that level. And so this is a resident, and in retrospect, I'm thinking, man, I would have loved to just sit down with him and ask him this list of questions that I passed out to define who he was and how he thought. And was he being truthful with us? I love, by the way, watching Big Brother, and I love watching Survivor, because I'm sitting there going, oh my gosh, he's lying to you. Don't you see he's lying to you? Don't believe that. He's going to vote you off the next second, the next chance he gets. Don't buy it, man. And so because you can see that, you get better and better at picking this stuff up and what the primary representational systems are and how you should address them. I often thought if I went to Survivor, I would figure everybody out, and I would go up to Erica and I would say, Erica, what did you see in that person? Because I know you're primary visual. Okay, so I'm going to use primary visual stuff over here. Can you see what I'm saying here? Can I write put out a diagram so that you can see this concept in front of you? Because it's hard to see a concept, right? Okay, Jessica was hard to teach because she was kinesthetic. I couldn't make her feel phosphorus. You see what I'm saying? That was difficult. I wrote stuff down. I made diagrams. Phosphorus, magnesium, the Rodney Dangerfields of the electrolytes. Don't forget those. But I just couldn't make her do anything. It was just fascinating. But it's trying to figure people out, whether they're sociopaths or whether they're truthful. And people often ask me, do you do this all the time? And the answer is no. It's too much work. I can't go out with a bunch of friends and sit there and go, oh, Hussein. So you don't always do that. You can't always do that because you're always trying to think about what I need to say next, right? You can't think about what you need to say next if you're thinking about what the person just told you, okay? Sometimes it takes an impartial observer like number 2 person in our little exercise. Well, all you were doing was watching, right, as opposed to asking the question. Yeah.
Thank you so much. That was awesome.
Thank you. Appreciate it.
I have just one other quick question. First, we talked about the resting faces and the eye movements and things when they are talking to us and we're getting to know those people. What are the cues that give you yikes?
Yeah. Okay. So when we were preparing this talk, we actually talked a little bit about this. And when I've been in charge of interviewing for internal medicine for, 15, 20 years, something like that. And so I actually, when I'm interviewing, up on the upper right-hand corner, I will put down their primary representational system. The first question I ask is, and this is how I set up the interview. Listen, Joe, I know everything about you that you wanted to tell me on the paper. Okay, all the nice things people say, and I'll smatter in there. Put in there some smatterings of Dr. So-and-so said you were the best person that walked on, water, resident that walks on water, whatever, student. I want to know who you are and what's important to you. So I'm going to ask you some things. What am I going to ask him? Think about what's most important to you. Think of it now. And I'm watching. Okay? We trust people in medicine. When was the last time you told a lie? Okay, I've already established what their primary representational system is. So now I know if they're going to be truthful with me. Okay, how do you feel about this? How would you feel about a resident who did this? Those are standard questions that we ask. We give them scenarios, one of 6 scenarios that we give. And our attendings actually have a set of questions that are behavioral questions that are meant to figure this stuff out. So one attending will ask these 3 questions, and the other attending will ask the other 3. And it works well when it works well. One time.
Are you looking to see that they're looking in the same direction when you ask them about lying as they did when you asked them about what was important?
Yes. Make sure it was congruent. And then later on when I ask them other things, I want to make sure it's congruent. If I ask them a question. See, the thing about, think about the last time you lied. I'm not saying see something or hear something or feel something. I'm allowing them to choose their primary representational system or think about something that's important to you. I'm allowing you to choose. Sometimes you say, you read people's mind, you don't know.
Did you tell them that you're not going to ask them to say it out loud, that you just want them to think about it?
I do ask them to say it out loud. Okay. I do ask them to say it out loud because then they go, well, why do you ask me that question if he doesn't want to know it? And I usually say, what are the 3 most important things to you? Leave medicine aside. 3 most important things to you in your life. And you can see people. I mean, every once in a while, people will go down here, and their eyes will get a little glassy. And I can say that. I can say something at that point. I said, when I asked you about the most important things in your life, and you got a little bit emotional, who were you thinking about? Right? I don't need to say what were you thinking. You're not thinking about your car. You're not thinking about your boat, right? You're thinking about somebody. Okay? Thinking about somebody. Or you can do stuff like this, which is a parlor trick, basically. Think about the most important thing in your life, and they go up there. So you're saying, okay, they're seeing something. They're not seeing a car. They're not seeing a house. They're not seeing their career. They're seeing their spouse, their parents, their child. So then you can go like this, and it blows them away. What's the first thing they tell you in the morning when you see them? How did you know I was thinking about so-and-so? One of the talks that I give, I actually interviewed a number of people, and we videotaped them. And so one of the questions is, who are the five people that you saw this morning? You know, follow up what they say to you. And one lady that goes like this. I ask them if they're handed, right? Because it's different for right and left. It's opposite for left-handed people. If you don't know that, Obama, when I first saw him, I go, oh my gosh, he feels things. He really feels this stuff. But he's left-handed, so it was all internal dialogue. It wasn't emotional. It was all internal dialogue. I was like, wow, I missed that. When I saw him, writing with his left hand, I was like, oh my gosh, he's left-handed. All the time I've been thinking he actually felt, that this was really important. So anyway, a lot of things happened during an interview that I'm taking note of. And at the end of the interview, we'll make assessments right away. DNR, do not rank. This person's not going to fit here. And anytime we've gone against one of our person's interviewers or whatever, DNR, we've always lived to regret it. We had a resident here a number of years ago that the program director DNR'd, and he ended up being here. I don't know how he ended up being here, but he ended up being here. Oh yeah, and man, it was just 3 years of, it was tough. We got him through it. We got him through residency, but we could have gotten 15 people through residency in the same amount of energy it took to get this guy through residency.
So, Paul, how long does it take you to assess up, so we have learners coming in and out, right? You're very practiced at this. So how long does it usually take you to assess somebody as you're talking with them about where they are and what their representational area is? So
it doesn't take long at all if you ask the right questions, and it's small talk. The person you're talking to thinks it's small talk. Man, those scrambled eggs just are not sitting well with me today. Did you have a good breakfast? What was it? They're visual. It's small talk. It sounds like small talk. And you think you're not getting, this sounds kind of nefarious, doesn't it? But this is what, Bob Jones did in Guyana or wherever. He killed his 900 people that decided they want to drink. Because these people who are sociopaths know how to use this in a way that gets people to follow them to do bad things. And you can use it for good. I hope we use it for good. But you can use it any way you want to, depending on what how pure your heart is. When you're interacting with folks. So it doesn't take long, but you got to be careful because you can get fooled. So in a person in an outpatient setting, especially a resident, you have the opportunity to know them over a period of time because they're going to be here this week and they're going to be here next week or whatever. Because we're not all the same, and the more educated you get, the harder it is for people to look at you. But you get microexpressions that'll give you away. But because then you use words that you've been taught to use. I can say I see. I can say I hear what you're saying. I'm aware of that, so I may actually change my speaking so that I will speak like you speak. That lady that was in the bed that we talked about. I tell people, we were talking to her in English, and she was speaking French. That's why we never got across. When we went to the other side of the bed, and we started speaking to her in French, she could now understand us. And matter of fact, she said, you're the first person that I've been able to communicate with in this hospital. And I thought, wow, that's amazing, because I know these other people. And they're great communicators. But I'm the first person that probably sat down on your left side. Everyone else did classically what doctors are supposed to do. Come on the right side, shake the hand, palpate the liver from here, listen to the heart from here, etc., right? That's what we do. And when we usually sit, where do we sit? We sit on the right side of the patient. We were never going to make a connection with her. Unless we noticed it and went to the other side. So with your residents, for instance, if you notice a resident is an internal dialogue, you're going to sit them on a particular side, and you're going to stand the other side, and you're going to bend over, and you're going to make them look at you in a place that they are comfortable with. If they're a visual auditory learner, you're going to sit even with them over to one side. And if they're a visual learner, okay, you're going to want to be a little bit higher than them because it's what they look like. Now, have you ever thought about in medical school why people always sat in the same chairs in the lecture hall? They sat in the chairs in the lecture hall based on how they learned. Teacher was here. I'm a big visual learner. I sat 2 rows up, 3 seats. No, 3 rows up, 2 seats in. So I was looking like this, taking notes, looking like this, taking notes, looking like this, because I was trying to place all that stuff in my visual cortex. This is how it was coming in, and this is where it was going back, right occipital lobe. Okay, and you had people in the back. And you go, and those were people sat that couldn't care less, right? It was the same when I was in medical school. People in the back that came in the back, and they were like, well, maybe they were there someday, maybe they weren't. You're like, well, is this guy in our class even? I mean, I never did see this guy because he sat in the back. Because it was all about different stuff for those people that sat in the back. Some people sat in the middle. Maybe they were more visual. Maybe they were more auditory. So we all have those things, and it doesn't take long to figure it out, but you always have to test it. Because people can be impressionable. I saw a show one time. I always like watching in addition to Survivor and Big Brother, but police shows. And they got these kids. They got them for committing some crime. I don't remember what it was. And I'm looking at this kid. I'm like, he's just confessing to this murder. And why is he lying? Why is he uncomfortable with his confession? Turns out the kid didn't do it. He got so scared. He confessed to a murder he didn't do, but you could see it that it wasn't correct. It wasn't right. This confession was not right. And in the police world, they look at the eyes, but they also don't have anything in front of them. They should not have a table in front of them. You know why? Because while the eyes may fool you if you don't catch, the hands do not. I am perfectly calm right now. No, I'm not. That's this. This is not calm. Okay, and I may have it down here where you don't see it, and say, I'm perfectly calm right now. I'm not. Or very comfortable with what's going on. And yet, my foot is pointing in this direction. I'm very comfortable with what's going on. I don't cross my hands because we all know what that means, but I cross my legs. Okay, and so and one policeman, FBI agent, says he always looked at the feet first, and he knew. By the way, there's a great study on people coming with chest pain, and it's just a video. And the question was, is this person's chest pain a coronary artery disease episode? Okay, and just with 15 seconds of looking, physicians were 70% accurate. No history, no physical diagnosis, no test. Stress test carries with a 65% sensitivity. And these people were 70% with just 15 seconds. And you know what they said? Obviously, this person's not having a heart. He's sitting there with his legs crossed. If he's sitting with his legs crossed, it's not a heart attack. There's no one's going to have that kind of pain and sit there with their legs crossed. Okay. There's another thing with peak flows, and this has nothing to do with crossed legs, but they're whether they're flat or upright and sweating, and it's almost a 1-to-1 correlation with peak flows over 220. This is adults, by the way, over 225, 140, and 70, based on their position.